Okay, evening, everyone.
Third
Good.
time.
All right, let's get started. Let me just share my screen here. Okay, so we're going to talk about the ulnar nerve, anatomy, compression neuropathies, and treatment and tendon transfers. Um, all right, so let's get going. All right, so the ulnar nerve um, comes from C8 and T1. So C8 and T1 form the lower trunk, which then splits into the posterior and anterior division. So the posterior division goes on to the posterior cord, and then the anterior division carries on as the medial cord. And the medial cord's got basically at 5 branches, and it's the way to remember it is 4MU. So 4 M's. So that's the medial pectoral nerve, the medial cutaneous nerve of the arm, medial cutaneous nerve of the forearm, the medial limb of the median nerve, and then the U is the ulnar nerve. All right, so if you look, you can see spoken about it before, the M. So the lateral part of the M is the muscular cutaneous nerve, and then the middle part of the M, or the lateral and the medial limb of the upper of the lateral medial cord, which form the median nerve, and then the inner part of the M is the ulnar nerve, which is there. I don't know if you can see my cursor. All
Yeah, I can see
right.
it.
Okay, so then just a bit more on anatomy here. You can see on the picture on the left, the artery goes through the middle of that M. So basically the plexus at that level wraps around the artery, and the ulnar nerve is this one here. It's in the anterior compartment in the upper arm, comes off as the M, then it travels down the arm, then it enters the posterior compartment through the medial intermuscular septum, goes down the elbow. The arcade struthers is where it enters the posterior compartment, and then it goes around the elbow. Importantly, there's no branches in the upper arm at all. The first branch of it is there's supposed to be an articular branch to the elbow joint, but to be honest, I've never even seen that articular branch. I think it's so small and it's completely irrelevant. So the first real branches that you need to be aware of are the FCU branches, which come off just distal to the cubital tunnel as it passes around the corner there. As it goes through the cubital tunnel, it passes under Osborne's ligament and Osborne's fascia, then through the two heads of the FCU, and then goes into the forearm. All right, once it's in the forearm, as I said, it goes through the two branches of FCU, and then it supplies the long flexors, which is FCU and the FDP, to the ring and the little. So it's a common mistake everyone makes when they get to hands, and also the junior guys. If you get a nerve cut in the distal forearm, a lot of people then think that you lose the FCU and the FDP to the ring and the little, but you don't, because those are innervated in the proximal forearm. So the only motor that you would lose if it's cut, the nerve's cut in the distal or mid forearm, would be the muscles in the hand. So just remember that the innervation is just below the elbow. This is just a closer look. You can see it coming around, going into the cubital tunnel there, and then it's entering Osborne's ligament, which forms the roof of the cubital tunnel. So once it gets to the hand, it enters Guyon's canal. It then splits into a motor and a sensory branch, with a motor branch going across the hand, and then the sensory branch continuing and supplying the little finger and the ulnar half of the ring finger. So the ulnar nerve has got very little innervation in the forearm muscles. The median nerve dominates in the forearm, but then when it comes to the hand, the ulnar nerve dominates in the supply of the muscles, and is really the main nerve that gives you motor function in the hand. So it supplies the hypothenar muscles, all the interossei, the adductor pollicis, half of the flexor pollicis brevis, sorry, not FDB, FPB, and then the medial two lumbricals. So the ulnar nerve is really important for strength of the hand as well as fine movement. So if your ulnar nerve's cut, you struggle to do small, delicate movements like doing up a button and those sort of holding a pen is even hard. So it's very important in dexterity as well as grip strength. All right. So then when it comes to examining for the ulnar nerve, the start off with the long flexors, which is FCU and FDP little. So FCU is quite easy to test for. You just ask the patient to flex the wrist against resistance, and then it's quite easy to palpate the ulnar nerve, the FCU um, under your thumb. It's quite easy to feel that. You feel FCR and FCU, and then you can test the strength of the FDP to the little. It's probably not worth testing the FDP to the ring because the ring is right next to the FDP middle, which is supplied by the median nerve, and there is a common muscle belly between the middle ring and little, so it's not as accurate. So testing the FDP to the little is more accurate than testing the ring. Can test abductor digitorum minimi. It's a bit difficult to do that, so we don't really do it much. The first dorsal interosseous is important to test though. Let me just go back to my presentation. Sorry, can you still see the presentation here?
Yeah, we can see it.
Okay,
Yes.
I've just lost it here. Okay. All right. Okay, so to test the first dorsal interosseous, the way I like doing it is you get the patient to lift the finger, you hold the patient's hand, then you lift their finger up to the ceiling like that. And with your other hand, you can just push it down. So what you do is you get the patient to stick their hand out in front of them like that. You hold the hand with two hands, you ask them to lift it up to the ceiling, and then you push down with your index finger. And anyone who's got an intact first dorsal interosseous, even a frail old lady, it's very hard to actually break that first dorsal interosseous. You can't push it down. At the same time, while you're pushing it down, you can actually feel that muscle over there is the first dorsal interosseous. So that's the best way to test it. And I find that's the most reliable indicator of the ulnar nerve motor function in the hand. You can do pad dab, asking the patient to open and close against resistance. You can also ask them to push against each other like that. And if the one ulnar nerve is weaker, you might see it collapses down like that. And then the special tests are Froment's, Jeans, and Wartenberg. So Froment's is this picture on the right. So when you ask a patient to pinch a piece of paper, a normal hand would use the adductor pollicis to pinch the piece of paper between the thumb and the index finger. But in the ulnar nerve palsy, you don't have adductor pollicis, so you need to make a plan with something else. So what they do is they turn their finger, gently pronate their thumb, and then they use the FPL to flex and hold that piece of paper. So that's a Froment sign. The one on the bottom is Jean sign, similar to Froment's, but what it is it's hyperextension of the MCP joint. And the reason that hyperextends is because half of flexor pollicis brevis is supplied by the ulnar nerve. So, but that is a variable supply. So in some patients, the whole of the flexor pollicis brevis is supplied by the ulnar nerve. And in those patients, if they're flexing against resistance, there's nothing to flex that MCP joint, so then they hyperextend it. And then Wartenberg sign is escape of the little finger. It's quite a rare sign, but some patients walk around and their little fingers sticking out like that. And it's not possible for them to close it. And it can be quite debilitating for them. They struggle to put their hands in their pockets and it often knocks things. So that's something that you see occasionally, but it's not very common. All right, so we'll go to entrapment of the ulnar nerve now. So it can be entrapped in really three places. So the first is the arcade of Struthers, which is where the ulnar nerve passes through the intermuscular septum, goes from the anterior to the posterior compartment in the upper arm. It's about 8 to 10 centimeters proximal to the cubital tunnel, but it's very, very rare. I've personally never seen that as the cause of the constriction. And it's not really important, but the one thing to remember is if you are going to transpose the ulnar nerve, you're bringing the ulnar nerve forward. So if it's a tight arcade of Struthers, that could be an area of constriction on the nerve. So you have to make sure that you release right up about 8-10 centimeters proximal to the elbow so that it doesn't get kinked at the arcade of Struthers. And then the most common area of entrapment is the cubital tunnel, and then Guyon's canal at the wrist, which is a lot rarer than the cubital tunnel. So what are the causes of cubital tunnel? Occasionally a bulging medial head of triceps. Some people have an accessory anconius, which is the anconius epitrochlearis. You all know that anconius is a muscle on the lateral side. Well, this is the sort of one on the medial side, which most people don't have, but some people have a remnant of it, which is called the anconius epitrochlearis. But the most common place is at Osborne's ligament and Osborne's fascia. So they're a bit difficult to really distinguish which is which, and there's not really a complete agreement, if you read different textbooks and things like that. But basically, Osborne's ligament runs um, from the olecranon across onto the medial epicondyle. So it's basically the roof of the cubital tunnel, and then that becomes Osborne's fascia, which really starts around where it starts entering the FCU. So those are the two common places for it to be trapped at the elbow. You can also get cubital tunnel caused by cubitus valgus. So it's an elbow which is a malunited fracture or medial collateral incompetence. And then they develop a tardy ulnar nerve palsy, which is a slow palsy that develops over time. It's quite rare though. And then you do see occasionally where it has a poor bed, the cubital tunnel. So that's anything that can irritate the nerve locally on the deep part of the cubital tunnel. And those can be from ganglions, arthritis with osteophytes. Sometimes it may be plates or screws there, which can be irritating the nerve as well. All right, so this is just showing those structures again. So the Osborne's ligament here, it's basically it's also a bit more proximal than this. On this drawing here, it goes from the distal part of the olecranon to the anterior part of the medial epicondyle, but it should be a bit more proximal as well. And then further down, it's Osborne's fascia. If you look on the bottom drawing, that's more as it's going through FCU. But yeah, they basically overlap each other. So it's classified by McGuire. So McGuire 1 is subjective sensory loss. So if you actually test them with pinprick or Semes-Weinstein filaments, their sensation is normal, but they do complain of pins and needles, paresthesia, and they do feel that the fingers are a bit numb, but there's no motor weakness. So they don't complain of any loss of strength. And McGowan 2 is where they actually do have objective sensory loss, and they do complain of weakness, and that's divided into a 2A and a 2B. The 2B with no atrophy, a 2A with no atrophy, and a 2B do have atrophy of the muscles. And then McGowan 3 is quite advanced, and they have a dense motor deficit and a dense sensory loss. All right, so when you examine the patients for cubital tunnel, the Tunnel sign is usually pretty accurate, pretty reliable here. I find with carpal tunnel, the Tunnel sign is usually negative, doesn't help much. But in the elbow, I think because the nerve is much more superficial, just tapping on the nerve there in a patient with cubital tunnel, they often get shocks and they don't like it when you tap on that nerve. So it's often positive in cubital tunnel. And then you need to feel for a subluxing nerve. And the way you do that is it's usually easiest to feel the nerve with an elbow and extension, and then you get your fingers behind the nerve, and you sort of bring the nerve forward, and then you flex the patient's elbow while you're bringing the nerve forward, and then you can see if it subluxes over or perches on top of the medial epicondyle. Another reliable test is the elbow flexion test. What you do is you ask the patient to flex their elbows maximally, and they must touch their elbows, touch their shoulders with their fingers, and they need to hold that position for a minute. And it's a positive if it starts reproducing the numbness or the pins and needles on one side as opposed to the other. And then obviously you need to do the motor and sensory exam. So I went through it just now about testing the first dorsal interosseous, the FDP, and the FCU. So in cubital tunnel, the FCU and the FDP to little and ring are weak, and that is a way of differentiating that from Guyon's canal. And then sensation, there's the dorsal sensory branch of the ulnar nerve, which comes off the ulnar nerve about 8 centimeters proximal to the ulnar styloid, and that travels dorsally. Then it supplies the back of the ulnar part of the back of the hand. So in cubital tunnel, that's is also numb, but in Guyon's canal, the nerve has come off before Guyon's canal, so the sensation there is normal. So that's the other way to differentiate the two. All right, so it can be a bit confusing. The ulnar nerve is a funny nerve sometimes. Sometimes it gives classic symptoms. Other times it's quite hard to really figure out if it really is cubital tunnel. So there are a few other things you must keep in mind. Parsonage-Turner brachial neuritis can cause weakness and paresthesia like that. This is normally a rapid onset associated with pain, and it's normally muscles of the nerve supplying the shoulder more, but it can affect the ulnar nerve. You can also get other causes of neuritis, but probably the more common causes and the differential would be from the C-spine. So prolapsed disc, irritating C8T1, and then thoracic outlet syndrome can also cause paresthesia, but that's normally the whole of the ring and the little finger, and it's associated with pain. It's intermittent, vague symptoms, pain in the neck, and then other neuropathies such as diabetes, Charcot-Marie tooth can present similar to cubital tunnel. All right, so when it comes to managing cubital tunnel, definitely in McGowan 1 and 2, possibly 2, you can consider conservative management. And that really, the two things you need to do is tell the patients to avoid flexion. And mostly it's when they're reading the book or playing on their phone and they're sitting there with the book quite close to them or their phone quite close to them. And you can tell them to actually try and keep the book or their phone a bit further away from them so they don't flex the elbow as much, or hold it in the other hand that isn't affected. The other time that it gets quite bad is at night. The reason is patients can fall asleep with their elbow flexed, and then the ulnar nerve is compressed for a prolonged period of time while the elbow is flexed. So to try and prevent that, you can get night splints, but it's really not well tolerated. I'm sure most of us tend to sleep with our elbows bent either on your side or on your stomach, and if you have to keep put a plastic splint or something or elbow brace on there to keep your elbow straight, it's not well tolerated. Some patients, you can actually tell them to take a towel, like a hand towel, and roll it up and then strap that to their arm so it's not completely rigid. So it does allow sort of 0 to 45 degrees of flexion, and that's a bit better tolerated than these rigid braces. The other thing to avoid is pressure on the nerve. So when patients are sitting at a desk, they shouldn't lean on the ulnar nerve at the elbow there. And then you can try a few other things, non-steroidals. Try a course of sort of 7 to 10 days of non-steroidals can help. Physios can do things called neural stretching, where they sort of take the nerve, they massage it, allows it to glide a bit better. But to be honest, I'm not sure if I really believe in that. But it's worth sending them to a physio, and it can buy time. And often these do settle eventually as well. So it could be worth sending them to a physio to tell them to work on that. But definitely there's no place for a cortisone injection in cubital tunnel. It's a very small tunnel, and if you try and get that needle into the tunnel, there's a very high chance that you are going to put the needle into the nerve and do an intraneural injection and make it much worse. So carpal tunnel, you can try it, but definitely not in cubital tunnel. So if you look at the literature, there are quite a lot of papers showing that it can improve with conservative management. One paper here by Padua showed 50% improvement just over time without doing anything. And Lee Dellon is a big nerve guy, and he showed that a lot of cases will improve with time, depending on the degree of severity. But the more severe the McGowan grade, the more chance you're going to need surgery. All right, so the indications for surgery. It's really failed conservative management. So variable amount of time, but there's no right answer there as to how long you must wait. But it depends how long the patient's had it and how they're tolerating it. But definitely if the symptoms are getting worse, then you need to operate. For me, definitely a grade 3 McGowan classification needs surgery. It's as soon as there's wasting and weakness, then I think you should operate. So probably the grade 2Bs should have surgery as well. So your options can release in situ, and that's either done open or endoscopic. Obviously, most of it's mostly done open, but there are ways you can do it endoscopically with a sort of um, a device that lifts up the skin. Obviously, it's dry. It's not it's not an arthroscopy, and then you can just release it endoscopically. There's no real benefit. It's just slightly better cosmesis, but to be honest, the scar is not very big for release in situ, and it's not in an area that is visible. So for me, an endoscopic is pointless. A lot of the time we do transpose the nerve, especially with if it's subluxing, but we'll come to the indications for that now. And the options for transposition is mostly subcutaneous, intramuscular, or submuscular. There is a thing that the Americans, it's a lot more popular in America, medial epicondylectomy. So that's essentially just taking away the medial epicondyle just proximal to the insertion of the MCL. And that essentially allows the nerve to move slightly forward during elbow flexion. So it's sort of like a mini transposition. So it just allows the nerve to move a little bit forward when you're flexing the elbow. But it's not something we do as the epicondylectomy. So what we do is for McGowan 1 and 2, especially 2A, we'll do an in situ decompression. And also, if you're going in there and it's a bad grade 3 wasting, weakness, and you go in there and you find that you release Osborne's ligament and fascia and you see a constriction, like an hourglass deformity of the nerve, then you know that you've released the constriction and you can actually stop there. So there's no need to transpose it. So it's basically saying if you find pathology when releasing the cubital tunnel, you can stop there. You don't need to transpose it. So the transposition is in where the nerve wants to sublux. If you release it and it's jumping forward, you need to move it. But just remember, if you're doing an in situ release, you're just releasing the roof. You mustn't lift up the nerve and release the deep part of the nerve, which is sort of adhered to the floor of the cubital tunnel. As soon as you do that and flex the elbow, it is going to sublux. So then you'd have to transpose every case. So just be careful. If you're planning to just do an in situ release, you mustn't release the deep part of the nerve from the floor of the cubital tunnel. Obviously, if it's a poor bed, osteophytes, ganglions, plates, screws, then you need to transpose it. Cubitus valgus, just doing a release, it's not going to work because that nerve's being stretched. You actually need to bring it forward. And then what I was talking about just now with McGowan's 3, if you find that the nerve was obviously compressed by the Osborne's ligament and you release it, that's enough. But if you release it and you don't, and the nerve looks normal, so there's no kink, no hourglass deformity, then it's probably from the nerve being stretched during flexion. So in those cases, then I think it's worth doing a transposition. So then you take it forward, takes the tension off it. So basically, if you're doing a release and you don't find pathology, transpose it. But if you do find pathology, you don't need to transpose it. I hope that makes sense. All right, submuscular transposition, it's a much bigger operation. You have to take the whole flexor mass off the medial epicondyle, stop at the medial collateral ligament. Sometimes it can be a bit tricky to differentiate the two. And then you put the nerve under the common flexor muscles, and then you need to reattach the muscle. So it's a much bigger operation than a simple subcutaneous transposition. So we don't really do it much now. The only place for it is really in revision cases where subcutaneous transposition has been done and it hasn't worked. And then you may consider it, some people do it for very, very thin patients. The reason being that if you do a subcutaneous transposition in those patients, the nerve's still going to be quite prominent and could get knocked and get irritated. as it doesn't have cover by any subcutaneous fat. All right, so just if you look here, look at the top picture on the right, bottom right picture. So it's mostly a dynamic problem, cubital tunnel. It's actually a very poor design, the nerve. As I said earlier, it goes from the anterior part of the anterior compartment in the upper arm to the posterior compartment, goes around the back, and then comes back into the anterior compartment of the forearm again. So it's really a bad design that when you flex it, it's really getting stretched across the back. This is in contrast to carpal tunnel syndrome, which is a static problem. So the roof of the carpal tunnel gets thick and there's reduced space in the carpal tunnel and it's there all the time. So with cubital tunnel, it's not there all the time. And it's really a dynamic problem mostly. And that's why nerve conduction studies really don't help you much, because the nerve studies are done with the elbow extended or slightly flexed. And most of the time, then patients aren't going to be actually feeling any symptoms of that on the nerve. And they don't do the nerve conduction studies with the elbow maximally flexed. So it really is a waste of time. It doesn't help you if you're suspecting cubital tunnel syndrome and the nerve conduction tests are positive. It's actually going to be very, very advanced cubital tunnel, because it's going to be a static problem by that stage. So the diagnosis would be obvious if the nerve conduction tests are positive, and if you're suspecting it and the nerve conduction tests are negative, it doesn't help you either, because it's then probably the dynamic problem. So it's a waste of time. Don't bother doing the nerve conduction tests. So if you look at the literature, there's no difference in outcomes between simple decompression versus transposition in most cases, even with 80% good results with simple decompression in a McGuire's 3 article in 2012. There's been quite a few prospective randomized control trials showing no difference in simple decompression versus anterior transposition, and definitely lower complication rates in simple decompression. So really over the last sort of 10, 15 years, the literature is really going more and more towards simple decompression as opposed to transposition. There's even been a couple of papers which have come out showing good results of simple decompression, even in nerves that are subluxing. But I must say, I don't think you can believe everything you read in the literature. So I really don't think that's a good idea to leave a subluxing nerve without a transposition. So yeah, it's difficult to say exactly what the best approach is, but I went through it just now. So really, in the McGuire 3s, if we find compression under Osborne's ligament, we don't transpose. But if it looks like a fairly normal nerve, it's probably a dynamic problem. So then we do transpose. But definitely test subluxation, make sure if it is subluxing or even perching, often it does just tend to perch on top of that medial epicondyle, then it should be transposed. All right, the other thing to watch out for is the medial antebrachial cutaneous nerve or medial cutaneous nerve of the forearm. And it occasionally has branches which goes across the cubital tunnel. You can see in the diagram there's two branches, often one proximal and one distal to the cubital tunnel. It's not often you see these, but if you do cut it, you can get a painful neuroma, area of numb skin, and patients won't be happy. So keep an eye out for them. Here's a couple examples. If you look on the nerve on the top left, you can see that area there, which is bruised. That's where the constriction was. It's been released. You can see it's sort of post-stenotic dilatation of the nerve. So in this case, it was the Osborne's ligament, which was the offending structure there. And here you probably won't need to try. I wouldn't transpose the nerve unless it was subluxing. Here's another one on the bottom right, where you can see a severe compression just distal to the cubital tunnel as it was entering the FCU. And here's a good example of those two branches. So there's the one cutaneous branch proximal, and there's the other cutaneous branch distal to the cubital tunnel from the medial cutaneous nerve of the forearm. Here's another one showing marked compression just proximal to the cubital tunnel with post-stenotic dilatation of the nerve. Okay, so yeah, this is sort of what I've already discussed this, so in the so basically saying a simple decompression is a subminimal transposition. Medial epicondylectomy is a slight transposition. just allowing slight movement of the nerve. It's a dynamic problem. Nerve conduction study is unhelpful. But it may have if you're not sure of the diagnosis and you're expecting like a neuropathy or something like that, it can be of use, but most of the time it's unhelpful. So when you do the cutaneous transposition, you must do a thorough dissection, bigger cut than if you're just doing an in situ release. You have to release right up until 8 to 10 centimeters proximal to the cubital tunnel. The first branches that come off are the branches to FCU, and they come off the posterior part of the nerve. So remember, you're bringing the nerve anterior. So you try and not, don't cut those branches to the FCU. You can just release them a little bit into the muscle so it gives a bit more length and allows you to transpose it. If you don't release those branches in going into the muscle, then often it tethers the nerve, and then you'd be tempted to actually cut the branch. You must remove part of the intermuscular septum proximally, just proximal to the cubital tunnel, because if you transpose it, then it goes over the sharp edge of the intermuscular septum and can irritate the nerve. So you actually resect a part of the intermuscular septum. And the most common reason we see from failed anterior subcutaneous transpositions is the nerve being kinked distally. So as it enters FCU, it can take a sharp turn. So you must make sure that you release enough of Osborne's fascia and the FCU muscle, split it just so that when it goes from being anterior and passing distally and then entering FCU, make sure it doesn't make too sharp a turn. And then you have to make sure it stays there. So you can't just go and close the skin after you've done the transposition. So what you do is you take a little bit of the soft tissue underneath the skin, which would normally be sitting over the medial epicondyle. You take that fascia and you suture it to the medial epicondyle. Some people make a fascial sling, but it's not necessary. Just suture the subcutaneous tissue back onto the medial epicondyle to make sure the nerve is staying anterior. Make sure the nerve is quite anterior when you're putting in those sutures so that you don't suture the nerve. And then don't take huge bites of the tissue either, because you could have a branch of the medial cutaneous nerve in that tissue, and then you're going to put a stitch around it. All right, so this is just sort of the flow diagram: simple decompression, anterior subcutaneous transposition, and anterior submuscular transposition. As you go down that path, then it's a bigger operation, longer recovery, more complications. So as I said before, anterior submuscular really just for very thin patients and in revision cases where you've already done a subcutaneous transposition. Excuse me. Okay, so we'll move on to Guyon's canal. It's a lot more rare. One thing I've seen over the years, and especially in private practice, some people will often do a combined release of Guyon's canal and cubital tunnel, and that's really not necessary. That's really just a sign that they don't actually know how to examine the patient properly, and they're not sure where the problem is. So if you're able to examine the patient properly, you should be able to reliably distinguish between these two. And as I said before, the difference is the FCU and the FDP to little are weak, and you lose the dorsal sensory branch innervation in cubital tunnel. And then on top of that, just the simple signs like a positive Tinel, a positive elbow flexion test, that all points towards cubital tunnel. With Guyon's canal, those are all negative, and you can actually often have, Tinel, positive Tinel, tenderness over Guyon's canal, and your FCU, FDP little, and the dorsal sensory branch are all normal. So you should be able to reliably distinguish the two. So with Guyon's canal, it's as the ulnar nerve enters the cubital tunnel, as it enters the wrist, it enters Guyon's canal, and in there it splits into two branches. It becomes the motor branch, which hooks around the hook of the hamate and goes across the hand. You can see in this cadaver specimen, it supplies all the small muscles. And then it continues on and then into the sensory branch, which splits into the sensory branch to the ulnar side of the little finger and into the fourth web space. So there are three zones. The first zone is before it splits. So if you have compression in that zone, you have motor and sensory fallout. Zone 2 is just the motor fallout, and then zone 3 is just the sensory fallout. All right, and the most common we see is usually the motor is the zone 2, where it's just a motor fallout. And it's really due to the proximity of the hook to the hook of the hamate, and it can either be caused by hook of hamate fractures, but most commonly it's due to compression on that. And you see it quite often in these mountain bikers who do these long rides like the Epic and Winds to Wales, and they actually come back after that and they've got a dense ulnar nerve palsy, motor only, which can actually hang around for weeks. But always just treat it conservatively. It almost always gets better on its own. There's no room to go and decompress the nerve. It's unnecessary. And it's basically caused by just continuous pressure on the handlebar between the hook of hamate and the motor branch. Okay, so that's the compression neuropathies and the anatomy done. So we'll go through the reconstruction of the ulnar nerve quickly. And yeah, there's three things that you need to address in the ulnar nerve, and that's the claw, weak grip, and pinch strength. The one, and a lot of these are caused by unbalanced flexion of the fingers, which is caused by the ulnar nerve palsy. And the reason you get that is because the ulnar nerve flexes the MCP joints through the interossei and the lumbricals. So without the ulnar nerve, you can see in the claw hand there that you get hyperextension of the MCP joint of the ring and the little finger. So if you're unable to flex those joints and you want to grip something, the only way you're going to close your hand is with the FDP to the FDS and the FDPs. So you tend to roll up the hand like that. And then if you try and grip an object, you can't actually get your hand around it. So gripping a bottle, when you grip a bottle, you actually have to, when you do it, your MCP joints flex first, and then you close your PIP and DIP joints. So without the intrinsics, which flex the MCP joints, you have unbalanced flexion, and that's what causes these problems. So it causes a claw and a weak grip. So the test here on the right is called the Bouvier test. And what that's doing is it's blocking the MCP hyperextension, and then testing whether the extrinsic extensors, so your EDC, are strong enough to extend the IP joints. And that's the positive Bouvier test is illustrated here, where the patient is able to extend the IP joints, and a negative Bouvier test is where it's been chronic and those EDCs tend to stretch out over where the central slip's going over the PIP joint, and it's no longer able to extend the PIP joint. So that's a negative Bouvier. And I'll come to that now. That's important when trying to reconstruct the nerve. So what we give to patients is a knuckle duster splint. So that's what you see on the bottom there. And basically what that knuckle duster splint does is it just keeps a inbuilt flexion into that MCP joint to allow the patient to extend the PIP joint. So after you've repaired the ulnar nerve, you need to give the patient one of these to allow that PIP joint to extend and prevent the extensor stretching out over time while you wait, and hopefully you can get recovery of those intrinsics, which would correct the claw. So when it comes to correcting the claw by surgery, basically what you want to do is build in a knuckle duster splint into the hand. So any technique that causes a flexion, increases the flexion of the MCP joint, will correct that anti-claw if there's a positive Bouvier. So that means that if you correct the MCP hyperextension, the patient will be able to extend the PIP joints. So that's when you can do the static transfer if the patient has a positive Bouvier test. So there's many described. Zancoli's big name in this, and the one we do really at Critiscare is the Zancoli lasso, which is the bottom right, where you cut FDS and then you bring it back on itself, cut it, pass it through the part of the A2 pulley, and then suture it back on itself. But you have to have an intact FDS to do that. So if the patients had a stab and it's cut all the flexors in the ulnar nerve, then obviously that FDS isn't going to be working. So then you cannot do that option. You may have to look at doing one of the others or do a dynamic transfer. So a lot of the world, the rest of the world, if they're treating just a simple ulnar nerve or leprosy or something, the Zancoli lasso is done a lot. But we tend to not be able to do it a lot because we tend to have bigger trauma and a lot of the flexor tendons are cut at the same time as the nerves. So when you have a negative Bouvier test, then you need to actually change your approach, and you just by putting an flexion moment at the MCP joint won't be enough. You actually have to do an intrinsic replacement. So that's what it means by dynamic, is you're replacing the intrinsics. So intrinsics, remember the intrinsics flex the MCP joints and they extend the IP joints. So that's the intrinsic position there. So the one we do is the brand ECRL four-tailed transfer. That's the one we normally do. What you do is you take ECRL. You can do a volar or a dorsal approach. The volar is better because if it doesn't work as an active transfer, it can work as a tenodesis effect. So you take the ECRL from dorsal, you pass it to volar, and then you take tendon grafts, palmaris, usually palmaris from both hands, split it into two, make four little tails, and then you attach it from ECRL, go through the carpal tunnel, and then when you get to the level of the A1 pulleys, you pass those grafts through the lumbrical canals, and the grafts then go dorsally. If you look at my cursor here, it then goes dorsally through the lumbrical canals, and then you can attach it either to the lateral bands. We tend to attach it slightly to the central slip. So now that's coming from volar, and it's going to put, when it contracts, it's going to pull on it's going to flex the MCP joint, and then it's going to pull on the extensor mechanism and extend the PIP and the DIP joint. So that's basically going to recreate what your intrinsics do. So that's going to improve your grip strength and it's going to correct your claw deformity. So that's our operation of choice. There is another one, the Stiles Banal, which is where you take the FDS to the middle finger and you can split it into four. And then you pass that through the lumbrical canals and suture it to the lateral bands. It doesn't improve your grip strength as much as the ECRL, but it does improve the claw and give you not too bad results. And then when it comes to the pinch strength, again, here you've lost adductor pollicis and you've lost the first dorsal interosseous. So those are the two things that you need for the palsy, for pinch, sorry. You need to get your thumb against your index finger, and then you need that index finger to be able to resist your thumb. So you need the first dorsal interosseous to abduct your little finger and the adductor pollicis to pinch something against it. So what we do, well, there's various things you can do. So first of all, index abduction. The one that we always do is the EIP to the first dorsal interosseous. But the other options, APL plus extended with palmaris to the first dorsal interosseous. Can do an EPB to the first dorsal interosseous. And then when it comes to the thumb, getting the thumb against the index finger, you can use the FTS, ECRB, brachioradialis. The problem with these is they pull the thumb in, which then closes the web space, and then the patients can actually battle. If it's a bit tight, you kind of have to set it up fairly tight to allow them to pinch. But then in the resting position, that web space is closed, and they can actually struggle to get the thumb out. So it's definitely not something we do. So what we prefer to do is fuse the thumb IP joint. So then when the patient wants to pinch, as in the Froment's sign, they're not flexing the IP joint of the thumb. That IP joint is fused in a straight position. So all that flexion moment then is transferred to the thumb. So you have a much broader area of the thumb, which pinches against the side of the finger. So that's the combination we do. Fuse the thumb IP joint and do EIP to first dorsal interosseous.